أهلا دكتور.
يا أهلا وسهلا.
دكتور نزار، وانت بدنا نتعرف عليك وجه لوجه
إن شاء الله بمي، إذا الأمور كانت جيدة نلتقي إن شاء الله في مي.
تمام.
ولو أنت في قلبي دائما والله دكتور مروان، من أول يوم اللي شفتك فيه.
تسلم تسلم عزيزي.
الله يخليك.
أنا مع الدكتور سداد حيجي
إن شاء الله.
تمام. طيب بتكون لقاء حلو
إن شاء الله.
مساء الخير، أهلا بكم جميعا في محاضرة هذا المساء، وهي محاضرة ستكون شيقة. Neurodevelopmental Disorder يقدمها الأستاذ الدكتور المعروف جيدا لديكم دكتور نزار أمين، أستاذ الطب النفسي في السليمانية في العراق. تفضل دكتور نزار.
شكرا جزيلا دكتور وليد. I would like to start by thanking Dr. Walid for these series of lectures and Zoom meetings since 2020 non-stop, and at the same time his initiative against the stigma of psychiatric disorders that started on the 22nd of February 2022 that will last for a year. Today's lecture is about neurodevelopmental disorders according to ICD-11, and the Arabic translation is اضطرابات النماء العصبية. And I would really like you to bear with me because it's going to be a bit long because the subject is very long. Now, these group of disorders are behavioral and cognitive disorders characterized by difficulties in the acquisition and execution of specific intellectual, motor, language, or social functions. The etiology is complex, and in many cases, really the etiology is unknown. The first one is disorders of intellectual development, and here the etiology is diverse. It's below average. And usually it is 2 or more standard deviations below the mean for this for that age and that group of people. Usually we need standardized tests to decide on the intelligence of the patient, but it's not always available. Therefore, clinical judgment might be useful, provided it's done by somebody who is qualified to do that. Now, among the disorders of intellectual development, it has been classified by ICD-11 into mild disorder, in which it is 2 to 3 standard deviations below the mean. And usually there's difficulties in acquisition and comprehension of complex language concepts and academic skills. Some of them, or let's say most of them, master basic self-care, and some of them might generally achieve relatively independent living and employment. And however, they require appropriate support. The moderate type is about 3 to 4 standard deviations below the mean, and usually, or let's say most of them are affected persons. They require considerable and consistent support in order to achieve independent living and employment as adults. You will notice throughout the lecture that I'll go through them quickly because most of them are repetitions like any other diagnostic criteria, so please bear with me. In the severe type, the intellectual development is affected, and usually they have 4 or more standard deviations below the mean for their age and so on. The affected persons, they exhibit very limited language and capacity for the acquisition of academic skills. They might also have motor impairments that they might need daily support in a supervised environment. The severe and the profound form are differentiated exclusively on the basis of adaptive behavior differences. It means that it's not easy to do intelligence tests on those people. So really the adaptive skills are the ones that we depend on a lot in the diagnosis. In the profound type, it's 4 or more standard deviations below the mean, and it's a profound type. The name is by itself, profound. And usually they have very limited communication abilities and capacity, and they might have co-occurring motor or sensory impairments, and they typically require daily support in a supervised environment. They are differentiated exclusively on the basis of adaptive behavior differences because, as I said, the standardized tests are not easy to apply on those people. Now we have a provisional category in the ICD-11. Here we are talking about infants or children under the age of 4 that might become later on intellectually impaired, or because they have sensory or physical impairment, or they have motor or communication impairment. And they might also have co-occurring mental and behavioral disorders. Now, I'm going to share with you some of the papers that are related to each subject, each category that I will talk about. The first one is this paper. It's from 2022. It talks about that human brain development is really affected by endogenous or exogenous factors. And the clinical sequencing studies have revealed that many of the neurodevelopmental disorders are either monogenic or monoallelic. Notably, chromatin regulation has emerged as highly dysregulated in neurodevelopmental disorders, with many syndromes demonstrating phenotypic overlap, such as intellectual disabilities with one another. Another thing is that epigenetic regulators are mutated at every level of chromatin organization. Understanding the mechanism of these mutations will illuminate common pathways between the disorders. Therefore, classifying these disorders based on their effects on the epigenome will not only aid in the prognosis in patients, but will also aid in understanding the role of epigenetic machinery throughout neurodevelopment. In another paper, which is relatively old, about 10 years old, it says that using a combination of human molecular genetics, gene by environment studies, in vitro pharmacological and biochemistry experiments, animal models, and investigations of non-biological bases of these diseases, such as environmental effects, will help. Many psychiatric disorders, including autism spectrum disorder, ADHD, etc., and schizophrenia can be triggered by alteration to neural development. In this paper, it's the same paper, it talks about using zebrafish. Experiments on them can be used to address two areas of future research: the contribution of environmental factors to disease onset and screening for novel therapeutic compounds. In this paper, it says that in the study, it shows high psychiatric morbidity in parents of children with intellectual disability. This is from India. Therefore, they advise screening parents of children with intellectual disability for any psychiatric disorders among them. Now, another category of the ICD is, among the neurodevelopmental disorders, of course, is developmental speech or language disorders. Here, of course, the disorder should not be due to regional, social, or cultural or ethnic language variations. And it should not be explained by anatomical or neurological abnormalities. The etiology, presumptive etiology for developmental speech or language disorder is complex, and in many individual cases, it is unknown. Among them, we have developmental speech sound disorder. And in this case, the acquisition, production, and perception of speech is affected. There are difficulties in that field, and there will be errors made on the overall quality of speech production that leads to reduced intelligibility of the speech and significantly affects communication between the affected people and normal people. In the developmental speech sound disorder, which is also called DSSD, again, it's not explained by social, cultural, or other environmental variations. And by the way, this part is very important in multicultural or cosmopolitan societies. It's very important. The speech errors are not fully explained by a hearing impairment or a structural or neurological abnormality. There are some inclusions and some exclusions in order to diagnose this condition. Now, we have developmental speech fluency disorder, in which the normal flow and rate of speech is characterized by repetitions and prolongations, sounds, syllables, etc., as well as blocking and word avoidance and or substitutions by other words. In the fluency disorder, the speech disfluency is persistent over time. It's not only in one situation or in one time. Also, it is markedly below what would be expected for age and leads to significant impairment. And it's not better accounted for by a disorder of any of these that are written here. Now, developmental language disorder, there's a difficulty in the deficits in the acquisition, understanding, production, or use of language, and lead to significant limitations in the individual's ability to communicate. It is markedly below what would be expected, and it's not explained by another neurodevelopmental disorders or sensory impairment, etc. Exclusions are ASD, etc. Now, we have developmental language disorder with impairment of receptive and expressive language, both of them, receptive and expressive. Here, receptive and expressive language is characterized by persistent difficulties in the acquisition, understanding, production, and use of language. Now, it is markedly, the speech is markedly, or the language is markedly below the expected level, and there's impairment in the ability to produce and use spoken or signed language. These are the inclusions: dysphasia or aphasia, receptive type, and there are exclusions. Now, in this case, a developmental language disorder with impairment of mainly, the impairment is mainly in the expressive language. In this case, it is mainly expressive, and the ability to produce and use spoken or sign language is affected in the expressive type. These are the inclusions, and there are some exclusions that will refute the diagnosis. Now, in this case, and of course, each one of them has its own code. The developmental language disorder is associated with impairment of mainly pragmatic language. So it is mainly pragmatic language which is affected, and there will be difficulties with understanding and use of language that makes inferences, understanding verbal humor, and resolving ambiguous meaning is affected. يعني إذا تنطي نكتة تحشير النكتة يمكن ما يضحك. Okay. Developmental, again, pragmatic, it is markedly below the expected level of that age or person, and the qualifier should not be, this should not be used if pragmatic language impairment is explained by other conditions. We have some exclusions, and in this case, it is associated with other specified language impairment. It is characterized by persistent difficulties in the acquisition, understanding, production, or use of language, and it is not adequately captured by any of the other developmental language disorders. So this is a separate category. Okay. Now, again, a couple of papers about the subject. This is by Amal Uthman. It says that between 5 and 12% of children aged between 2 and 5 are diagnosed with speech or language delay. 50% of these children experience delays that persist into adolescence and face educational and occupational challenges later in life. The delay varies, and it is really, some of them are born with physical or physiologic conditions that impede speech, and others have cognitive or developmental conditions. And the risk factors include male sex, prematurity, low birth weight, low birth order, larger family size, maternal or intimate partner violence. In this paper, it says primary prevention should rest on some theories, and its interaction of the child's learning capacity with the language environment. These theories support parents' education and public programs that increase children's exposure to child-directed speech. In this case, male sex, bilingual environment, birth order, chronic otitis media, and effusion, in this, according to this paper, are not adequate explanations, so different opinion, for clinically significant delays in language or speech. Sex and environmental and genetic factors explain primary language and speech disorders. Secondary or tertiary prevention requires early identification of children with language and speech disorders in association with chromosomal, genetic, neurological, or other health conditions. The literature points to substantial variation in this subject, in this type. However, according to this paper, differences in musical abilities counts, and this subject has not yet been incorporated these individual differences into the childhood speech and language problems. Therefore, they propose, the authors, the atypical rhythm risk hypothesis, which posits that individuals with atypical rhythm are at higher risk for developmental speech language disorders. In this study, types of speech sound errors this is from Mandarin speaking areas. Mandarin speaking children and are compared with those co-occurring developmental language disorders. Children with co-occurring SSD, specific sound disorders and developmental language disorder, demonstrated the least accuracy of speech production among the three groups of people. Right. Sound speech disorder and developmental language disorder. In them, co-occurring sound speech disorder with developmental language disorder showed more frequent use of these mistakes, substitution of omissions, etc. And the results suggest that the disorders in speech sound production in children with speech sound disorder and developmental language disorder may be associated with underlying phonological linguistic processing. Another category is the autism spectrum disorder. Here, according to ICD-11, there is a deficit in the ability to initiate and sustain reciprocal social interaction and social communication, and a range of restricted, repetitive, inflexible patterns of behavior, interests, or activities. The onset is usually early, during the early developmental period, and it may not become fully manifest until later, when the social demands increase. Also, they have impairment in personal, family, social, educational, or occupational or other important areas of functioning. It has a pervasive feature, and it might vary according to the social or educational or other context in which the child is in. And some of them might exhibit a full range of intellectual functioning and language abilities, and we're going to talk about them in the coming slides. These are the inclusion and exclusion criteria. Now, ASD without disorder of intellectual development and with mild or no impairment of functional language, in this case, the intellectual functioning and adaptive behavior are found to be at least within the average range. They have only mild or no impairment in individuals' capacity to use functional language. While here, when there is with impaired functional language, in this case, at least within the average range, there will be marked impairment in functional language, and the individual is not able to use more than single words or simple phrases. Okay, in this case, all the definitions for or requirements for ASD are there, and the disorder intellectual development are met. And of course, in this case, there's a disorder of intellectual development with marked impairment in functional language. So both intellectual development is affected and functional language is affected too. In this case, there is ASD without disorder of intellectual impairment, but with impaired functional language. So all features of ASD are there, but without disorder of intellectual impairment, with impairment in functional language. Now, in this one, there's ASD with disorder of intellectual development and with absence of functional language. In this case, there is complete or almost complete absence of ability relative to the individual's age to function. Right. These are also related to ASD. Now, a couple of papers on the subject. The diagnostic validity has a debate, and it is its differentiation from high functioning autism. So we have an entity called high functioning autism differentiated from Asperger syndrome. The present study aimed to examine whether Asperger syndrome differed from high functioning autism in clinical profiles and to analyze the impact of DSM-5's innovation. The conclusion of this paper is that Considering the available evidences and the results, even continuing to use the broad category of ASD, as Wing stated, a number of changes need to be made in order that the future version of DSM-5, DSM at that time, it was 2011, might be used reliably and validly in clinical practice and research. ASD category of DSM-5 had the merit to have solved lots of previous classifications, discordances, and splitting approaches. Nevertheless, it could be meaningful to introduce the additional subtype specifier, which is high functioning, the autistic disorder or Asperger disorder, in order to grant the recognition of different nuances of the spectrum. And now, in this paper, ASD affects more than 1% of children. This is 2020. Of course, the number increases year after year in Western societies. And of course, there are a lot of discussion about why the number increases, whether it's an actual increase or not. Anyway, there is improved recognition, screening, clinical assessment, and diagnostic testing. So the use of new genetic technology is helpful in the diagnosis, and up to 20% of individuals with ASD are now diagnosed with genetic syndromes or have chromosomal abnormalities, including small DNA deletions or duplications, single gene conditions or gene variants, and metabolic disturbances with mitochondrial dysfunction. The heritability estimate for ASD is between 70 to 90%. Still, there is a lower molecular diagnostic yield than anticipated. So there must be a multifactorial causation with etiological heterogeneity. And of course, it is affected by epigenetics. So the authors emphasize prioritizing treatment based on targeted symptoms for individuals. Each case should be taken on his own merits with ASD, as treatment will vary from patient to patient based on diagnosis, comorbidity, causation, and symptom severity. In this paper, they believe that 1 in 59 individuals can be diagnosed as ASD and is a costly disorder across one's lifetime. And the prevalence, costs, and range of behavioral needs early intervention is vital to teach skills. Interventions based on applied behavior analysis have the most empirical support. So from the beginning until today, this is probably the most common way of dealing with ASD children. Now, another category is developmental learning disorder. This is, it affects or leads to difficulties in learning academic skills, and it may include reading, writing, or arithmetic. The skills are markedly below what would be expected, and there's impairment in the individual's academic or occupational functioning. It first manifests when, usually when the child goes to the kindergarten or to the school during early school years, and it's not due to a disorder of one of these that are written here. Okay, now the developmental learning disorder could be with impairment in reading. In this case, skills related to reading, such as word reading accuracy, reading fluency, and reading comprehension are affected. The reading is markedly below the average for its age and so on, and it is not due to a disorder of intellectual development. These categories are mentioned in all the criteria. That's why I'm going through them very quickly. Now, disorder, developmental learning disorder with impairment in written expression, there will be difficulties in learning academic skills related to writing, such as spelling accuracy, grammar, and punctuation accuracy, and organization and coherence of ideas in writing. اللي عندهم مشكلة بالإنشاء, I think this is partly due to this. Okay, so We have impairment in written expression. They have markedly below what would be expected. And also it is not due to a disorder of intellectual development. Now, this one is with impairment in mathematics. I know a lot of people who have impairment in mathematics. In this case, learning academic skills related to mathematics or arithmetics, such as number sense, memorization of number facts, accurate calculation, fluid calculation, and accurate mathematic reasoning is affected in those people. It is markedly below what would be expected with other people, and it's not due to a disorder of intellectual development, etc. Another category is with other specified impairment of learning. In this case, learning academic skills other than reading, mathematics, and written expression are affected. And it is not due to disorder of intellectual development, etc. In this paper, it says that dyslexia and dyscalculia are frequently studied to inform our understanding of cognitive development, genetic mechanisms, and brain function. They discuss limitations of this research approach, including the use of arbitrary criteria to select groups of children, heterogeneity within groups, and overlap between domains of learning. Therefore, they argue that we need to overcome the problems associated with the categorical approach by taking into account interacting factors at multiple levels of analysis that are associated with overlapping rather than entirely distinct domains of learning. The conclusion is that this will allow for a richer understanding of learning and development. It is imperative that researchers continue to look for the causes of learning difficulties. It is necessary to abandon outdated and questionable approaches, and they embrace new methodological and conceptual directions in the quest of more informed influences. In this paper, they compared groups to dyslexia, children with dyspraxia, with or without dyslexia. They had who had more problems with speech and language planning and planning in everyday life. Children with dyspraxia without dyslexia had more frequent early motor delays and deficits in visuospatial production than the other groups. The dyslexia group predictably demonstrated poorer single-word reading and phonologic processing compared to the dyspraxia-only group. In conclusion, they think that cognitive problems with planning are particularly relevant in those cases. Another group in the ICD-11 is a developmental motor coordination disorder. In this case, there are significant delays in the acquisition of gross and fine motor skills, as well as execution of coordinated motor skills, and usually it is markedly below what would be expected for the individual's chronological age and level of intellectual functioning. They are typically apparent from early childhood, and there will be persistent limitations in functioning. And they are not solely attributable to diseases of the nervous system or neuromuscular, musculoskeletal system and so on. Okay. Now, in this paper, they think that the developmental coordination disorder is a neurodevelopmental disorder that affects children's ability to execute coordinated motor actions, resulting in slow, clumsy, or inaccurate motor performances and learning difficulties. Children with developmental coordination disorders exhibit a diversity of motor signs, and these are the motor signs that are here. Now, in this paper, 1.8 to 8% of children And also there's deficits. 4 main hypotheses are postulated here, including deficits in visuospatial function, procedural learning, internal modeling, or executive functions. And it is due to a disorder of the parietal, frontal, and cerebellar cortices. The motor coordination skills are significantly below the expected level for the age of the child. The deficit has an impact, or must have an impact, on activities of daily life, leisure, etc., and it should not be secondary to a neurological condition. And the prevalence is around 5%, and the diagnosis is based on questioning of the family as well as clinical examination. Interventions should focus on activities that are essential to the child's daily and school life. Now, the common condition, attention deficit hyperactivity disorder, according to ICD-11. It should be a persistent disorder, at least 6 months, and it should be prior to the age of 12 years. And there will be difficulty in sustaining attention, as well as hyperactivity, which refers to excessive motor activity, and there will be impulsivity, and there will be manifestations of inattentive and hyperactive impulses. I'm going through them quickly because I'm sure most of you are aware of the terms. It's just where to put them and how to put them. It is evident that it must be evident across multiple situations, and it varies according to the structure and demands of the setting. So according to the context, and the symptoms are not better accounted for by another mental or behavioral disorder. These are the inclusions. Now, we have the predominantly inattentive presentation, where the inattentive symptoms are the predominant ones. There will be problem or difficulty in sustaining attention. However, that doesn't mean that they don't have hyperactivity or impulsivity, but they are not clinically significant in relation to the inattentive symptoms. In this case, the hyperactive symptoms are the predominant, hyperactive impulsive symptoms are predominant rather than the inattention, and it is evident in structured situations. And impulsivity is a tendency to act in response to immediate stimuli without deliberation or consideration. However, that doesn't mean that there is no inattention, but it is clinically less significant. However, we have a combined presentation, Allah yasa'ad al-ahl, when there are both of them are present, in which neither is predominating. This is like the schizoaffective disorders that was present before. Okay. Also, the hyperactivity refers to excessive motor activity, while impulsivity is a tendency to act in response to immediate stimuli. Now, we have this category of stereotyped movement disorder. In this case, the condition should be persistent at least several months. It's not ما محدد 6 months like the previous one. And the movements are stereotyped, apparently purposeless, and often rhythmic. They are not caused by the direct physiological effect of a substance, and they markedly interfere with normal activities and result in self-inflicted bodily injury, but this is not always, as we will talk about it. The stereotyped movements that are non-injurious or non-injurious can include body rocking, head rocking, etc. And the behaviors include repetitive head banging, face slapping, etc. Okay, now We have stereotyped movement disorder without self-injury. In this case, the disorder is there and it markedly interferes with normal activities, but do not result in self-inflicted bodily injury. Okay, and in this case, they are not caused by the direct physiological effect of a substance. And the stereotyped movements that are non-injurious can include body rocking, head rocking. I talked about that before. Now, with self-injury is another category. In this case, there is self-inflicted bodily injury that's significant and requires treatment. In this case, the stereotype movement disorders are purposeless, often rhythmic, and it might include a head banging, face slapping, eye poking, high khatra jiddan, and biting of the hands, etc. Right. Now, a couple of papers about movement disorders. Rhythmic movement disorders consists of repetitive stereotypic movements such as head banging or body rocking, etc. This review of childhood rhythmic movement disorder highlights the lack of systematic research into core aspects. It's not tempting to do research on it, of the condition, relying heavily on small case series or case reports. The interpretation is further limited by almost universal failure to confirm the core diagnostic criteria. Nonetheless, a number of themes range. Rhythmic movement disorder is likely to start in infancy and have a developmental course with spontaneous resolution in early childhood. In many cases, that is, of course, provided that the child has not inflicted an irreversible injury on itself. And the factors associated with the persistence are unclear. There is a pressing need for systematic approach to classify rhythmic movement disorders, etc. In this paper, the movement disorders are stereotypes that begin before 3 years of age, and the primary motor stereotypes occur in children of normal intelligence, whereas the secondary ones occur in a setting of an additional diagnosis such as autism spectrum disorder, other neurologic disorders, and usually there are comorbidities, psychiatric and others. Stereotypic, again, in this here it involves frontostriatal overactive dopaminergic pathways and underactive cholinergic and GABAergic inhibitory pathways. There are no genetic markers, and future studies will focus on identifying genetic markers and on better understanding the functional and structural neurobiology of these movements. Here, the study confirms that children with primary stereotyped movement disorder show a widespread dysfunction of gross and fine motor abilities, and highlights that this may be evidenced even in preschool age. This observation could delineate a peculiar phenotype and could provide new approaches to the management of this neurodevelopmental disorder. In the disorder in preschoolers show motor functions could take advantage from treatments for improving their motor abilities. And this in turn could reduce the lack of self-esteem and the tendency to withdraw from and that characterizes children with developmental coordination disorder. This paper suggests that the basal ganglia feedback plays a central role in preconditioning cortical networks to anticipate self-generated movement-related perception. Therefore, behavioral policies may preferentially rely on new data versus existing knowledge. This may inform creative art therapies in conditions characterized by stereotyped behaviors. In this systematic review, Appraisal clinical evidence of movement disorders in patients with Rett syndrome is studied, and this allows, the study allows for more robust genetic counseling for families, but can also assist healthcare professionals. The synthesis also showed that environmental enrichment would be beneficial for improving some aspects of movement disorders. The cerebellum, basal ganglia, alongside dysregulation of the corticobasilar ganglia, thalamocortical loop, are likely anatomical targets. Of course, a review of treatments for movement disorders also help to provide recommendations for treating and managing movement disorders in patients with Rett disorder. Treatment of Rett disorder or syndrome would require a combined pharmacological and biopsychosocial approach. Recent evidence has demonstrated that pre-symptomatic training in a mouse model of Rett syndrome can help to manage symptoms and delay the onset of functional impairment. Now, this is neurodevelopmental disorders unspecified. These disorders, I'm sorry, I didn't have the English version of it, so I'll just mention them in Arabic. And the most important one is the Tourette syndrome, while the others, I'm sure you know very well about them. The subject was very long. I didn't know how to present it for you, but I did my best to go through them very quickly and show you some of the papers related to the subject. I really thank you for your tolerance, and I'm ready for questions.
شكرا جزيلا دكتور نزار على هذه الرحلة المرهقة لك، صحيح، ولكنها مفيدة. يعني مع أني أنا من سنوات مشارك بالفيلد ستاديز للICD-11، لكن هذا الجزء من الICD-11 is very complicated، خصوصا أن العديد من هذه الديسوردرز ليست شائعة أن تراها في العيادات، هي موجودة في المجتمع، لا تصل إلى التقييم، وبتحتاج كلها ل neuropsychological testing that is not really available. But as you mentioned rightly, إنك يعني بتشوف كل يوم يقول لك هذا الطالب مجتهد وعلاماته عالية، لكن الرياضيات يستحيل أو كذا يستحيل، والintelligence تبعه واضح إنه should be enough to do it. المشكلة اللي يمكن السبب اللي أنا بشوفه إنها not seen clinically، إنه most of these things management تبعها مثلا في speaking و writing وإلى آخره هي في educational system. فبيشوفوا الإخوان في educational psychology much more common في المدارس تحديدا. If they have the tools, they can discover nearly all these disorders. Unfortunately, many of the tools known worldwide have not been translated and standardized in the Arabic environment, and it's making things difficult. الواقع بأنه يعني أنا برأيي إنه الزملاء وخصوصاً الحاضرين من اليونج جنريشن جداً مهم معرفتها، لأنه في كثير من الحالات زي مثلاً stereotype movement خطأً، بما أنه في stereotype movement شخصوا على أنهم أوتيزم. هو الواقع ما في أوتيزم، في بس stereotype movement، أو stereotype movement شخصت على أنها tick disorder. يعني هناك عدم وضوح فيها، وكثير من الجوانب مثلا تعتبر for many colleagues إنه خلص هذه يعني ما لها حل، مع إنه كل الإيفيدنس بدل إن الانفايرمنت تغييرها، التعليم enriching the environment, many psychosocial intervention, psychoeducational intervention could help. but يعني given الاستسلام وإنه ما في شيء نعمله، ما وإنه في دواء نعطيه ماشي، بس هذا ليس مبرر لإنكار وجود disorders حقيقة موجودة. أشكرك جزيلا دكتور نزار. نفتح المجال دكتور مروان، تفضل.
أنا لما بسمعك دكتور نزار ولما بسمع دكتور وليد دكتور سداد، مش بس أعجب في قيمة المادة اللي بتنجاب، إنما في الأساس في إعطاء مثال لمهنيين updated متابعين المستجدات، وهذا يعني درس لازم يعطى لكل المشاركين في المجموعة، إنه الشخص ما يكتفيش في اللي بيعرفه، إنما دائما يكون updated. هذا الموضوع رجعني لأحد التخصصات اللي عندي، اللي هو أنا يعني متخصص في الإديوكيشنال وكمان في الديفلوبمنتال، واشتغلت سنين في هذا المجال، وأقمت أول مركز للخدمات النفسية للمدارس يعني في مدينة الناصري، هذا من سنوات طويلة، واشتغلت كثير في هذا المجال. اللي بدي أقوله هيك، أولاً هاي الكاتيجوريز اللي انذكرت أهميتها بتكون بقدر ما في أطر علاجية ملائمة للكاتيجوريز المختلفة. طالما ما فيش هاي الأطر، الكاتيجوريز هاي بتضلها ما لهاش لزوم، إنما بتضلها مهمة للكوميونيكيشن بين السايكولوجيين أو بين السايكاتريست، إنه نفهم على بعض فلان عنده أوتيزم، فلان عنده ليرنينج ديسابيليتي، فلان عنده كذا كذا. بس هي أهميتها لما بنحدد نعمل تشخيص لولد معين، هذا التشخيص لازم ياخذنا لنوع علاج معين. هذا متعلق في اطر التعليم الخاص الموجود في البلد وانواعها، لانه في كثير انواع تعليم خاص، في صفوف اللي عندهم مشاكل في الكلام، في صفوف للاوتيزم، في صفوف للريتارديشن، في طرق علاج واطر علاجيه للي عندهم ليرنينج ديسابيلتيز. طول ما شبكه السبيشال اديوكيشن متنوعه، هاي الكاتيجوريز كثير مهمه. اما اذا مش موجوده وما فيش كمان مهنيين زي occupational therapist او speech therapist، كمان بضل يعني كاتيجوري تكتب على الورق وبالكوميونيكيشن بين المهنيين، بس بيكونش في منها فايده. فاهميتها في وجود اطر، ويمكن كمان اهميتها في انه هي تحث لوجود اطر. لما في عندنا مجموعه اطفال في بلد معين اللي شخصوا عندهم اوتيزم، ساعتها بصير في الحاح انه هدول مجموعه بدهم نوع معين، بدهم صف خاص للاوتيزم. او اذا في مجموعه ثانيه عندها اضطراب ثاني، بيكون في مطالبه بايجاد مهنيين وعلاجات ملائمه لهذا الاضطراب. هذا واحد. الشيء الثاني منيح كمان ما ننساش انه هذا الشخص هو اكثر من الدياجنوسيس اللي اعطيت له. يعني شخص مع نفرض مايلد ريتارديشن، هو كمان عنده شخصيه معينه، ممكن يكون عنيف، ممكن يكون منطوي، ممكن يكون هو كمان ابن العائله، ممكن تكون عائله داعمه او عائله فقيره او عائله منكله، او فمهم نضلنا شايفين الصورة الكاملة للولد أوسع من التشخيص اللي يعطى حسب الاي سي دي 11. الشيء الثالث اللي بدي أقوله إنه دائما بيرافق اضطرابات أخرى، يعني بالذات لما بيتمش تشخيص الولد بشكل سليم ولا يعطى العلاج الملائم، بدنا نتوقع إنه ممكن هذا الولد يطور anxiety، ممكن يطور depression، ممكن يطور aggression. فيعني الشغله بتبداش وبتخلص في انه هو عنده اضطراب معين ديفلوبمنتال، انما يضاف له اضطرابات ثانيه مع الوقت. بخصوص الاختبارات النفسيه، اختبارات التشخيص، طبعا لازم يكون في ستاندرديزيشن، بس كمان لازم يكون في ملائمه ثقافيه. وانا بهذا المجال اشتغلت سنين. انا لاني فتحت اول مركز ما كانش في عندنا ولا اختبارات بالعربي. كل الاختبارات انا اشتغلت على تطويرها وملائمتها للمجتمع العربي وعملان تقنين وستاندرديزيشن. بس بدي اشير لبعض الشغلات المهمه في التشخيص. بكفيش ناخذ اختبار ونترجمه ونعمل له ستاندرديزيشن، بمعنى نشوف شو هي المتوسطات تبعت البلد، انما لازم الانتباه لعدد من الشغلات. فهي الاختبارات اغلبها سرعه الاداء هي عامل مهم. إذا سرعه الاداء مختلف من مجتمع لمجتمع. في مجتمعات بتمشي حياه الاطفال والناس على الساعه، بتكتكوا على الساعه. في مجتمعات حياه الناس ماشيه حسب الطقس، مع شروق الشمس وغروب الشمس. اللي متربي في مجتمع اللي بيمشي وقته أو برنامجه حسب الطقس أو حسب الشمس، يعني صعب ينجح في اختبارات اللي بتقيس الأداء بستوبر. هذا واحد. الشيء الثاني، في مهارات مختلفة من مجتمع لمجتمع. يعني أنا بشغلي كنت أشتغل مع يعني مجموعات بدوية. البدو عندهم قدرات تفوق القدرات اللي موجودة في أوروبا وفي أمريكا في بعض المجالات. يعني مثلا تنبؤ حالة الطقس، البدوي بيقدر يتنبأ حالة الطقس بدون ما يسمع نشرة الأخبار. اختفاء الأثر أو التدبر بالمساحة المفتوحة بالصحراء، مش بحاجة للجي بي اس. علاج بالأعشاب، رعي أغنام، توليد أغنام. يعني نأخذ ولد أو تين ايجر بدوي بدبر حاله في هاي الشغلات، نجيب واحد من نص نيويورك أو باريس اللي هو بتعلم في أحسن المدارس، سلموا هاي الشغلات بضيع. فيعني في مهارات اللي هي cultural يعني dependent أو متعلقة في الثقافة نفسها. إذا بدنا نعمل اختبارات لأشخاص معين نقيس ذكائهم، بدنا نحط ايتمز في الاختبار لتلائم الثقافة تبعته. كمان في كل قسم في كل اختبارات الذكاء في قسم معلومات عامة. ستوقف أي معلومات عامة بنحط. هل نسأله عن بيتهوفن أو شايكوفسكي، ولا بنسأله عن عبد الوهاب وأم كلثوم، أو بنسأله عن أديب فلاني غربي ولا أديب عربي؟ فهذا كلياته ملائمات ثقافية لازم تجري في عملية التقنين والملائمة. الشيء الثالث، وهي ملاحظة أنا لاحظتها كمان، لها علاقة في الأداء في التجربة الثقافية. أنا لاحظت إنه الطلاب العرب عندهم صعوبة بالمقارنة مع مجموعات تانية، عندهم صعوبة في اختبار اللي اسمه comprehension. بهذا الاختبار بيسألوا أسئلة إنه شو بتعمل لو مثلا بيسألوا ولد شو بتعمل إذا بتلاقي محفظة متروكة في سوبر ماركت أو في دكان، هو أنا بدي أخذ قرار. أو شو بتعمل إذا ولد صغير بيجي بتحرش فيك أو بضربك، ولد أصغر منك، شو بتعمل؟ إذا الطالب العربي أو الولد العربي متعود يقولوا له شو يعمل وشو ما يعملش، وهذا المأزق ما مرقش عليه، يعني بتردد وبعطيش إيجابي شافي زي واحد اللي تربى منه وهو صغير إنه هو يعتمد على نفسه، يأخذ قرارات ويجادل. وهي واحدة من الفوارق في الأداء اللي بتبين في الاختبارات. ملاحظة أو تنتين إضافيات على ال ADHD. واحدة من الشغلات اللي أنا بلاحظ إنه كتار من السيكولوجيين بخربطوا فيها هو بين ADHD بين شخص اللي هو موجود في حالة انكزايتي عالي أو في حالة دلال زائد وبدون حدود. في أولاد اللي بتربوا في دلال زائد وبدون حدود بفوتوا على غرفة العلاج أو الفحص بنط من شغلة لشغلة من شغلة لشغلة، فدغري الواحد بفكر إنه هذا عنده ADHD، أو بيكون في حالة ستريس أو ضغط. الفرق بين ADHD الحركي في عند ولد عنده ADHD بين ولد اللي عنده دلال زائد أو بيعرفش الحدود، أو اللي عنده anxiety. اللي عنده anxiety أو دلال زائد الحركة تبعته بتكون هادفة، يا هادفة للهروب من إشي بخوف، أو الهادفة إنه بده يحصل على إشي اللي مش عارف الحدود تبعته. بينما ال ADHD كثرة الحركة تبعته هي شبه عشوائية، وهذا واحد من الديفرنشال فاكتورز اللي ممكن الواحد ياخذها في الاعتبار عشان ما يخربطش بين ADHD بين كثرة حركة تاني. طيب أنا بكتفي في هذا حاليا، شكرا.
شكرا جزيلا. هل هناك من أسئلة أو تعليقات استيضاحات من الأخوان؟ بروفيسور
السلام عليكم.
عليكم السلام. أهلا دكتور صفي.
عفوا ان قطع النت، بس اذا ممكن اشارك او قبل البروفيسور.
تفضلي.
ايه يعني شكرا استاذنا دكتور نزار على المحاضره القيمه والمهمه، واللي نحتاج حقيقه ان ناخذ الموضوع باهتمام اكبر. عندي كم تعليق احاول امر عليهم سريعا. يعني اتمنى هاي المحاضره مثل ما ذكرت استاذنا دكتور وليد امكانيه ترجمتها للعربيه وإعطائه بشكل مبسط إلى معلمات المرحلة الابتدائية. يعني اللي أشوفه أنا في مجتمعنا، يعني المشاكل هم من سوء فهم هاي الحالات من قبل المعلمات. يعني يفصلون الطلاب اللي يعانون من هاي المشاكل في ركن من الصف، ويتم يعني السخرية والتنمر عليهم للأسف من قبل يعني بعض المعلمات حقيقة قبل الطلبة. يعني بالتالي اللي ما عنده أزمة نفسية يعني راح يصير عنده، واللي عنده راح تتأزم الأزمات أكثر. بالنسبة للماثماتيكال، يعني هي باي ذا واي ليس هو التشخيص العلمي للأسف. يعني الآن أصبح مشكلة عامة، لربما بسبب وجود الحاسبات. يعني للأسف أشوف بعض طلاب طب ما يعرف يحسب عملية حسابية بسيطة، لربما هو قلة الممارسة. إطلاق الأحكام من قبل بعض التشخيصات، وحتى للأسف من قبل اللي هم نيورولوجيست على هاي المشاكل، أنه هذا عنده لو اي كيو، أو حتى يسموه لا يزالون mentally retarded، ويعني يعطون تشخيص وللأهل يعني يخبروهم أنه خلص هذا ما منه أمل. يعني يأتوني الأهل أنه الدكتور الفلاني قال أنه هذا خلص لا تتعبين عليه وما منه أمل. يعني حتى لو كان يعني مثلا الديجري اوف اي كيو مودريت أو مو مثلا سيفير. للأسف هم وجود هاي المراكز الغير متخصصة وغير علمية، استغلال هاي الحالات وتفتح لأغراض تجارية أو لأغراض إنسانية، لكن أيضا غياب التخصص والعلمية بها، على اعتبار أن هاي المشاكل هي تعالج سلوكيا. أخيرا عندي قصة لحالة طفلة أيضا تم تشخيصها على أنه intellectually disabled. يعني جاءتني العيادة كان عمرها تقريبا 9 سنوات، وتم تشخيصها على هالأساس، وأيضا تنمر من قبل المدرسة. قعدت حقيقة مع الطفلة بعد يعني أخذ الرخصة من أمها أقعد معها لوحدي. تأكدت أنه الطفلة في المرحلة الأولى الابتدائية كانت متفوقة بالدراسة، وإحنا في مدينة الموصل فترة داعش يعني اللي صارت 3 سنوات تقريبا تأخر، وبعدها صاروا يسموها مرحلة عبور. المهم يعني ما معقولة طفلة في الأول ابتدائي كانت متفوقة وفجأة تشخص mentally retarded مثل ما هم يذكروه. فطلعت الطفلة عندها أعراض PTSD. شافت واحد يعني داعشي وماسك شخص، وأخبروها أهله أنه هذا رايح يشنقه إلى آخره. فالطفلة تكونت معها صورة لمشهد كامل هي ما شافته لكن بالإيماجينيشن، وظلت تعيش هذا المشهد سنوات وهي الأهل ما يعرفون بها. الحمد لله يعني عالجناها بالبيهيفيرال فور يعني PTSD for children من خلال متخصصين، والطفلة رجعت يعني لأدائها الدراسي اللي كانت معهودة عليه. وشكرا جزيلا.
شكرا جزيلا. Anybody want to add؟
دكتور عبد الخالق.
دكتور عبد الخالق.
Unmute yourself دكتور عبد الخالق. You are mute. One click only. one click on the mute.
بأسفل الشاشة على الشمال.
إلى أن يدخل علينا دكتور عبد الخالق، بس أحب أضيف دكتورة صفية thank you for your comment. تفضل دكتور عبد الخالق. الماثماتكس هي مو فقط كالكوليشن، الحقيقة المودرن ماثماتكس تدخل الآن في كل يعني جوانب الحياة. شلون السايكولوجي والفلسفة الفيلوسوفي تدخل في كل جوانب الحياة، نفس الشيء الرياضيات الآن تدخل في كل جوانب الحياة. لذلك the impairment in mathematics is not only arithmetics, it is real mathematics. إلى أن يتحضر دكتور عبد الخالق، أحب أضيف الدكتور مروان شكرا على تعليقاتك. الحقيقة أنا كنت أعمل في منطقة في الصحراء وكان ماكو شوارع، وبالليل السائق كان ينقلنا إلى مركز المدينة حوالي ساعتين طريق يعتمد على النجوم فقط، وهو بدوي. نقطة أخرى أحب أضيف إلى أن يتحضرون الأخوان في منطقتنا، في منطقة كردستان العراق، وأعتقد في العراق أيضا، موضوع التربية الخاصة كانت غير مهمة في قبل يعني عقود معينة. الآن أصبح اهتمام كثير جدا بها من ناحية وزارة التربية، في معلمين أو مدرسين للتربية الخاصة، وفي الجامعة فتحت فروع خاصة أو أقسام خاصة بالتربية الخاصة.
لا سوري دكتور نزار، أنا أحاول أساعد اللي مش عارفين يفتحوا المايك فقفل كل المايكس. أوكي.
هسه أوكي. الشيء الآخر أنه أصبح شغف كثير من قبل الأخصائيين الجدد في الصحة النفسية، في يعني الخريجين الجدد في منطقتنا، الشباب في هذا الموضوع. الآن أكثرهم يزورون المدارس ويسجلون محاضرات على اليوتيوب. هذا جزء من اللي تقوله الدكتورة صفية، بارتلي لأنه يحبون أن يخلوهم يعني الناس تتعرف عليهم أنه هذول أخصائيين، بس بنفس الوقت المردود هو كبير جدا، لأنه يفتحون دورات للمدراء المدارس الأساتذة، وهذه سببت قفزة كبيرة في خدمات التربية الخاصة في منطقتنا.
دكتور عبد الخالق.
Yes, دكتور.
تفضل.
Thank you very much, دكتور, and thank you for Dr. NAZAR for a nice presentation. I'm Dr. عبد الخالق, third stage, Kurdistan Higher Council for medical specialty. I have only one question just for clarification if it's possible. Dr. Nazar, if it's possible, I don't know when we spoke about stereotype movement disorder, did we talk about Lesch-Nyhan syndrome or not?
Not specifically. Yes. This is a category which is stereotype movement disorder. We are not really talking about syndromes. ما أعرف إذا أستاذ وليد عنده تعليق على الموضوع.
So this is
كل السندرومز المعروفة لا تدخل في التصنيف. يعني هي السندروم منها ما يسبب mental retardation وبيلبسي، منها كل سندروم حسب ما هو موجود، فلا تدرج بعادة في الاي سي دي السندرومز، بل يعني يستعمل الجزء اللي يعني يشخص بأنه هذا عنده mental intellectual disability with Lesch-Nyhan syndrome for example. بس هذا additional diagnosis not coded لا بالاي سي دي ولا بالدي اس ام.
Yes.
Yes, Doctor. Afan, this is my question. How clinically we can differentiate between this syndrome and stereotype movement disorder? Like, how clinically we can differentiate, and the treatment, what's the difference between them?
The diagnosis, according to the DSM or according to ICD, is really depends on a group of symptoms, and together we give it a code. Lesch-Nyhan syndrome is something else. I mean, the patient might have some of these symptoms, but that's a different kettle of fish. I mean, that is a syndrome, and this is a diagnostic criteria. And by the way, I forgot to mention that this kind of classification might not be very well accepted by a clinician like me, who has been practicing for about 40 years now in the field, or 44 years in the field of psychiatry. But if I want to do a research, or one of my students like yourself want to do a research on these subjects, the diagnostic criteria, the ICD and the DSM are the best tool to depend on to conduct that research, because you can really depend and to create a specific diagnostic criteria. And if you fulfill these criteria, then the patient has that disorder. As far as the Lesch-Nyhan syndrome is a clinical condition, that's completely different. But of course, the patient might have symptoms of some of these disorders that I mentioned in the classification of ICD.
Okay, thank you very much.
Thank you.
هي تعليقات، أسئلة، إضافات؟ أن تجاوزنا الوقت. تمام. في النهاية نشكرك دكتور نزار مرة أخرى، وأعتقد أنه هذا اللي قدمته وثيقة مهمة إذا أمكن مشاركتها مع الزملاء، لأن بها الكثير ليقرأوا بتمعن وبتفصيل.
راح أدز لك إياه بعد شوي إن شاء الله.
إن شاء الله. شكرا جزيلا، تصبحون على خير. محاضرتنا الثلاثاء القادم هي TMS Transmagnetic Stimulation in Psychiatric Disorders. إلى اللقاء.